And today we will be focusing on advanced care planning. So we do have many of our hub members here today, and I'm sure we are all familiar with them, so I'm not going to introduce everyone. For those who are new or might have missed some of our previous sessions, you can access all the recording, the slides, and many of the other resources that have been presented in our previous sessions, all of these on the iEcho platform. And so before we start, I'm going to hand the session over to Farah for some housekeeping and announcements. So thank you, Farah.
Thank you, Grace. Hold on, I'll just share some slides. So today will be our last session on the session today will be on advanced care planning. So just some housekeeping rules just to make sure to include your name, area of expertise, and also country as your screen name. And also if you have any questions at any point of the session, please put your questions in the chat box. And we also encourage all of you to turn on your video, and please use the mute button if you're not using if you're not speaking. We also will record the sessions and upload all the recorded sessions on YouTube, as well as the learning materials on the iEcho platform. And we also have translated captions. So if you need some translated caption, you can turn it on Zoom as well. And also for Malaysian clinicians, to fill up the CPD form later, I will share the link on the chat box so you can fill up your information for you to claim the CPD points. Yep, for the agenda today, I think I'll pass back to Grace to start the session.
Thank you, Farah. So today we are very honored to have our first speaker, Sister Cheng Hong. Sister Hong is an infectious diseases advanced practice nurse from the National Center for Infectious Diseases at Singapore. She is currently leading an HIV comorbidity clinic that delivers holistic care to people with HIV and with comorbidities, especially metabolic syndromes. And in addition, Sister Hong is running a geriatric syndrome screening clinic that addresses age-related health concerns in people aging with HIV. So Sister Hong is going to talk to us on advanced care planning. So thank you, Sister Hong.
Thank you, Dr. Grace. Good days to all. So I'm going to share my slides. Just give me a moment. Just checking, are you seeing my slides?
You'll just need to change the view.
Okay. Okay. Thank you very much for having me here today to share our experience on advanced care planning in PLHIV from Singapore experience. So this will be the brief outline of content that we're going to cover in the next 20 minutes. So before we go into the sharing proper, may we get your help to answer some questions just to learn our current understanding about ECP. If I may get Farah to help me launch the poll questions. Thank you, Farah. Okay, so this is the first question. When should ACP discussions ideally begin in PLHIV? So do we know how many participants has responded?
21 so far for the first question.
Okay. Maybe we can move
there's
to the
more
second
than
question.
There's
Oh,
more
sorry.
than 23.
Okay. Okay, maybe I can move to the second question.
You want to share the results of the first
Yep.
question?
Okay, since we are at question number 2, we can probably answer the second question also. So which is the following is patient-related barrier for ACP uptake? Is it limited access to trained facilitator? Or is it cultural belief that talking about death is a taboo? Or is it lack of time in a busy clinic? Or is it inadequate documentation systems? Okay, I think if we have, I'm not able to see how many responses we have. Maybe we can show the result and just see.
All right, hold on. Do you want to see the first question first?
And
All right, hold on.
okay, great. So about 91% choose early in the disease trajectory and with periodical review. Okay, excellent. Response for number 2. Here we have a little bit more diverse answer or response in question number 2. So we do keep this question in mind as we go through the sharing and see whether we have an answer at the end of the sharing. Okay, thank you very much. We can move to question number 2, which is the last question.
Hold on, sorry for the third questions. I have some difficulties here.
Sure, no worries. Okay, maybe I will start the sharing. So, okay, HIV has shifted from fatal illness to chronic condition, and the PLHIV population is aging. This demographic change have bring complex multimorbidity issue characterized by rising prevalence of age-associated comorbidity such as cardiovascular diseases, cancers, and dementia. Despite these growing health needs, stigma against PLHIV persists. This complicates disclosure and preventing candid conversation about death and dying. And the ACP or advanced care planning is frequently a missed conversation among PLHIV. This leads to poor quality of life at the end of life stage, unwanted medical interventions, and the significant uncertainty from the families. And the end-of-life care planning in PLHIV faces multiple challenges. This is rooted in our cultural and structural norms. So we know that family-centered care model often prioritize the collective decision from family over individual preference. This creates conflict with patient autonomy. In our region, the social culture hesitance to talk about death worsen these issues. And the families are often put into the position to make medical decisions, which carries conceptual pitfalls because family may lack of expertise in making medical decisions, and there may be possible conflict of interest, and the complex family dynamics, estrangement, or fear of blame can hinder open discussions. Additionally, religious belief often influence end-of-life choices, sometimes conflicting with medical advices. So what is actually holding us back from ACP discussion, right? Physicians may feel uncomfortable initiating ACP discussion due to lack of time in the busy HIV clinic with very high patient loads. Many doctors and nurses feel ill-equipped to handle sensitive conversation or manage patient and family's emotion. And clinicians may also feel uncertain about predicting HIV disease trajectory, especially with multiple comorbidities. And some believe that ACP discussion is outside of their scope of practice, assuming that it should be handled only by palliative care teams. And the resistance may also come from our patient. Many patients do not know what ACP is or misunderstand it as a sign that death is near. The fear of discussing ACP may inevitably lead to disclosure of HIV status to their family or to community. Therefore, they may avoid this important discussion. But what exactly is ACP? So ACP is a structured process that supports adults of any age or stage of health in understanding and sharing their personal value, life goals, preferences regarding future medical care. It reduces the need for crisis decision-making and builds trust. So we have touched on some misconceptions about ACP earlier. So ACP is not the same as do not resuscitate order. ACP is an ongoing dialogue, not just an event. And the ACP is not just about refusing treatment. It has a much broader scope. So the objective for ACP is to help our patient to have a say in their healthcare if they no longer have the mental capacity. So in Singapore, Advance Care Planning, Advance Medical Directive, and Lasting Power alternately serve distinct but complementary roles in future care planning. They differ significantly in legal status, scope, and purpose. I will go through a little bit more details. In terms of purpose, ACP focuses on healthcare-specific preferences across various scenarios, but it does not grant legal authority beyond the scope of documented discussion. AMD exclusively addresses end-of-life care by authorizing the doctor to withhold extraordinary life-sustaining treatment only when the patient is terminally ill, unconscious, and the death is imminent. LPA, on the other hand, covers broader decision-making. It involves personal welfare, property, finances, when a person loses mental capacity. In terms of legal status, AMD and LPA are legally binding documents under Singapore law. But ACP lacks the statutory enforcement. It only functions as a conversational process. But for AMD and LPA, if one want to change, or it has to go through a formal revocation processes. But ACP is very flexible. The care preferences can be updated without any legal formality. So this will reflect evolving health status and the value that patient may hold. So in Singapore, there are 3 different kinds of ACP. General ACP for people who are generally healthy. Disease-specific ACP for people who have progressive life-limiting illness and probably at a higher risk of suffering multiple complications. So preferred plan of care, in short PPC, for patients who are approaching the end of life and usually has less than a year's prognosis. So when should we start the conversation? Well, life is unpredictable and we never know. So we should start while we still can, right? But there are some common triggers for ACP discussion. It can be disease-related, for example, when there's a newly diagnosed metastatic cancer, when there's a new major comorbidity such as stroke, heart attack, or end-stage renal disease. Patient with declining functional status, early cognitive impairment, or having recurrent hospital admission also offer a good opportunity for ACP discussion. So in the next session, I'll be sharing some practical tips on how we conduct general ACP and the PPC. So for general ACP, before we starting the session, we explore patients' knowledge about ACP. And we introduce ACP as routine care and also share with them the purpose and the benefit. When we explore patients' understanding about their health condition by usually saying, can you share with me what do you know about your condition? Or do you have any concern about your health? We give the patient ample time and space to share their thoughts. We probe them further if need be. And throughout this session, we can also help to address any concern they may have, which they may not have time to bring up in their regular visits. So next, we will find out patients' experience with any family members, friends who have become seriously ill. So we will get them to reflect and share their feelings and thoughts about it. And if this would happen to them, will they do anything differently? Okay, so another important aspect for ACP discussion is to explore the concept of living well by asking a series of questions. So we will ask, what is important for you to live well? What gives you life meaning? Sometimes patients may not have a ready answer for us. They may take a while to think. We can throw in examples like being able to travel around, being able to enjoy the food I like, or being able to be independent in my daily life, or not being a burden to my family members. So these are making me, feel I live well. So we explore what they fear and the worries about their health, and how do they deal with crisis or stressful situation in life in the past. So, sorry, excuse me. So we introduce the role of nominated healthcare spokesperson and guide the patient to choose their NHS. Usually the NHS must be older than 21 years old, because 21 years old in Singapore is a legal age. And the person must know them well, willing to speak up for them, and can be trusted to act in their best interest. And the most important thing is that this person must be able to make decisions under stressful situation, right? So the next stage, we will explore the goal for medical care for severe injury or illness. It is not easy to cover this part of conversation. So we take a first step by framing the goal of care discussion based on comfort care and the life-sustaining treatment. So we provide patients with examples for different goals of care to help patients contextualize the conversation. And for patient who is not ready to decide at the point of discussion, okay, we can ask the following questions as a guide. So for example, what will help you to decide on this? And what would you like your medical team to focus? And what would you like your medical team to avoid? If it is still left undecided, we will then set a date to follow up with the patients. So then we will need to ensure that the patient's NHS is agreeable with that decision. If there's any concern, they should voice out at this point in time to clarify. So we also provide opportunity and space for them to have any conversation during this time. So lastly, explore if patients' religious belief or personal belief may influence is the care preference. And do they need any support or help to help them to address this, right? So when we conclude the discussion, we usually obtain patient and the NHS consent and signature so that we could publish the ACP within our electronic health record so that it can be accessed by care provider from various institutions across Singapore. Because there's no point that we have a beautiful discussion or documented, but other people who's providing care may not be able to see, right? So the final section of today's sharing, I'll be briefly introduce the discussion on treatment decisions when we conduct PPC, right? So PPC is actually generally start with a general discussion for understanding patients' value, healthcare belief, which is very similar to the general ACP part, right? But patients' preference of treatment decision is what we will usually focus on. The next table actually is a session taken from the PPC form that currently we are using. So we document patient's preference on CPR if he or she is in cardiopulmonary arrest. We will provide detailed explanation on the risk and the benefit of CPR and provide some brochure for patient's reference. Sometimes patients may give us very conflicted views. So for example, I do not want CPR, but I want intubation. I do not want ICU care, but I want CPR and intubation. So we have to rationalize with them that all these things comes in the package and just choosing one may not work, right? So in section B, we discuss the possible medical intervention and explore patients' preference on different interventions. So taking the limited additional intervention as an example, we may initiate some trial of treatment. It could involve IV or intravenous medication. But if patients fail to show any clinical improvement, we will then move on to comfort measures, right? So people who's choosing this limited additional intervention usually does not want endotracheal intubation. They do not want to be transferred to intensive care for further care and management. All right, so additional care preference can be discussed here. It could be disease specific. For example, does the patient want dialysis? Does the patient want artificial nutrition support, NG tube feeding, or using antibiotics through IV, or having blood transfusion? So all this discussion will be documented properly together with the rationale. We literally write down everything patient writes, patient says. So the last session allows us to explore where the patient prefers to be cared for and the preferred place of death in any event of deterioration. So sometimes patients may choose to be cared for at home, but when they deteriorate actively, they still want to transfer back to hospital and to pass on in the hospital, which is nothing wrong because they feel that this process of handling death will be too much of a burden for the family members to handle. So they will still prefer to have healthcare providers dealing with this. So noting down patients' preference with rationale is very important. So I think this will be the last slides of my sharing. So I hope this provides you with a flavor of how ACP discussion for PLHIV in Singapore is conducted. And also hope to provide you with some bring home message so that you can conduct ACP conversation and feel comfortable about it. Yeah.
Thank you very much, Sister Hong. So this session is now open for discussion. So we welcome any questions for Sister Hong on this very important topic. So you can feel free to raise your hand if you have questions, or you can type in the question in the chat box. Sister Hong, you've mentioned this very important role of the nominated healthcare spokesperson. So for people with HIV, one of the I think issue is the disclosure of HIV status. So I do actually have quite a number of older patients who actually have never disclosed their HIV status to anyone since the time of diagnosis. So for these individuals, do you think if they want to discuss about ACP, is this nominated healthcare spokesperson an essential person in the ACP planning? And whether the disclosure of HIV status is essential when they select a close family or friend to be this spokesperson.
Okay, thank you so much, Dr. Grace. I think this is an excellent question, especially very close to our PLHIV population that we look after, who is elderly, single, estranged from family members, and basically very thin social support. So for this group of patients, it is even more important to discuss about advanced care planning, because we can let them know that not necessarily you must nominate one of your family members, who you may not be in contact for many years, to come for the session. But you could let us know who do you want to trust to help you make the medical decision. It can be medical team. So the patient can still share with us their wish of how they want to be cared for. And then we document it down so that the managing team will become patient spokesperson. And this brings me to the next step. Yes, usually the patient may want to plan their last rites, right? If they do not want to disclose the status to family members, sometimes they may be somehow known to our social worker. And they can also actually nominate one of our social workers to help them handle. Because somehow not in Singapore, in hospital, we still have this rule and regulation that upon patient with HIV pass away, we have to hand a memo to their family members to say that you have to go to this specific funeral planners to help you arrange, because some of the undertaker have a special training to handle this kind of situation. And this, although it's not openly disclosure of HIV status, but somehow will raise the suspicion from the family, and they can Google, they will know, oh, this undertaker is specially taking care of these blood-bound diseases. So that's the issue. If they can bring forward the discussion of how they want to plan the care, we can help them make a plan. And the social worker will be alerted when anything happens. So that's why I hope that I have, bring the message across that it is especially important when our patients have no one. It is good for us to know what they want, how they want to plan their care, and what is in their best interest, right? So rather than, by default, we should save everybody. So we will send the patient to ICU with a CPR, with intubation, which may not be what patient wants. Yeah, so I hope that answered the question.
Yeah. Are there questions from our participants? Yeah.
Sorry, can I just check? For example, such scenario in terms of death, this is based on the cause of death is HIV-related causes. But if it is not, then they don't have to go through the whole process of this, right? for the HIV?
So the current situation that even the patient pass away with some unrelated condition like pneumonia, for example,
Mhm.
right? At the end of it, we do not put HIV status in the death cert, right? But it's when we handle the COA, how come this is different, especially when they have handled this portion with their other loved ones. We say, how come this is different? How come now I'm given a restricted list of undertaker that I can go to, right? So that's the difference, right?
So if
It
they
doesn't matter what is the death of cause.
really? Wow, okay.
Yeah. So a lot of patients actually do not pass away because of HIV-related issues, right?
Mm-hmm.
It is very common. This is from cancer, from like pneumonia or other age-related issues now.
The provider they die at the hospital lah, because
Yes.
of the complication.
Yes.
Okay, but
Yes.
what happens if they are they die at home? They don't want to go to hospital, and then the cause of death is not it could be pneumonia, but then again pneumonia can cause not just HIV, other causes as well. So
Sure.
they don't have to go through the whole processes for HIV under the HIV, right?
So there are few scenarios for patients who maybe pass on in a home, in their own home. Number one is that this person already known to a home care provider.
Okay.
Right. So when that is the situation, then the home care provider will still know about the HIV status. Right. So then it all goes back to the same. If this person does not known to any home care providers and there's an unexpected death at home, usually the GP who would conduct home visit will not help to sign up the death cert.
Oh,
So
okay.
the body may still be request to bring back to hospital and go through the similar processes.
Could you enlighten me how many are basically in general last 1 year? How many are such cases like that? Do you have the figures?
I'm afraid I do not have the figure.
Okay.
Yeah.
Thank you,
Sure.
sister.
Thank you.
Sister Hong, so in the practice in Singapore, who usually conducts the ACP discussion with the patient? So are there healthcare personnel who have received specific training, or it could be any physicians, nurses who have been taking care of their patients?
Okay, a very good question. So we have ACP course. And the ACP, like I shared, there are 3 different type of ACP, right? So for general ACP, even our care coordinator, social worker, they are very comfortable doing this, right? For disease-specific ACP or maybe PPC, which is a little bit different because it touch on some like a medical decision, which usually the physician or the nurses will be trained. We have to go through a course to complete this training. And after we go through the course, we have to clock number of cases that we have conducted just to keep the skill warm. So we have rolled this out as a national program whereby we try to encourage more healthcare workers go for this. They doctor, nurse, APN, social worker, coordinator, as long as they feel they were comfortable, they can sign up the course. Yeah, so for APN, usually we encourage all the APNs to go through this course because it really makes a difference to patients' care. Yep.
Okay. So, in the interest of time, maybe we will go on to the second talk first, and then we can go back to our discussion. So, may I now invite Dr. Chris Choi to present the case. Dr. Choi is an infectious disease specialist from the Princess Margaret Hospital in Hong Kong. And one of his areas of interest in HIV medicine is HIV-related malignancy, in which integration of advanced care planning in HIV care is, of course, very important. So Dr. Choi will be presenting a case where ACP was an important part of the management plan. So thank you, Chris.
Thank you for a kind introduction. Let me share the screen. Okay, hello. I'm Chris from Hong Kong, an ID physician. Let's start my case here. Okay, this is the first two. This is a very sorry. This is a 32-year-old gentleman, Mr. K, heterosexual, single, live alone. His only family member is his mother. He previously worked as a convenience store manager. He has his HIV diagnosis in 2017 with, at the time, baseline CD4 count is 24, viral load 7 log. The past history include also the CMV-related esophageal ulcer, esophageal candidiasis, latent syphilis declined lumbar puncture, and treated with intramuscular benzophine The patient was put on Genvoya, later switched to Biktarvy. However, the patient defaulted follow-up in 2022 for more than 1 year. He then returned to our clinic follow-up in April 2023. At that time, his CD4 count is 8 with HIV viral load 5 log. He was found to have pancytopenia and esophageal candidiasis, treated with fluconazole and resumed Biktarvy. But 2 months later, he presented with gum swelling. The gingival biopsy confirmed Kaposi sarcoma with presence of sleep-like vessels and also vesicles of spindle cells with immunohistochemical stain diffusely positive for HHV8. At that time, after 2 months of resumption of the ART, the CD4 count is 68 and the viral load is 3 log. A bone marrow examination was done for pancytopenia, which showed hypercellular marrow with evidence of hemophagocytosis. Bone marrow aspirate, bacterial, exifas bacilli, fungal culture, parvovirus PCR were all negative. A PET-CT scan done and confirmed hypermetabolic skin lesions in scalp with extensive lymphadenopathy, involving bilateral neck, mediastinum, axillary regions, abdomen, presacral, bilateral external iliac, and also left inguinal regions. There was hepatomegaly with multiple liver metastases. After discussion with the patient, the oncology team suggests for liposomal doxorubicin in view of systemic disease. The gum and facial swelling initially improved with 3 cycles of chemotherapy. However, there was disease progression in September, with contrast CT showing interval progression of the hepatic lesions and also involvement of the right lower loop of the lung with pleural effusion. Unfortunately, there was increasing size of the gum tumor with active bleeding. He was given frequent supportive transfusion and radiotherapy to the gum. His case was further reviewed by the oncology, which offered second-line chemotherapy. However, he developed aspiration pneumonia. He could not tolerate oral diet due to progressive obstructive symptom requiring total parenteral nutrition. At that time, patient was very Caucasic. He was primed further chemotherapy of ultra-high risk in view of underlying disease. After family interview involving the patient, mother, and oncology team, the patient opted not for further chemotherapy in order to avoid prolonged suffering. Palliative care was accepted by the patient's mother. There was increasing abdominal pain requiring use of morphine. In this case, there are various elements to be considered in our advanced care planning. Regarding the disease-related factors, the prognosis of the disease is really poor and its complications. To the patients, his experience of the disease and also his experience of the active treatment, his rapidly declining functional nutritional status, and his wishes for the quality of care. Last but not least, we need to take account for the family concerns and worries as well. As a final wish, the patient requests home. We explained to patient and mother the high risk of further deterioration while not under monitoring in the hospital. They showed good understandings. Advance Directive with a refusal of CPR and DNA CPR form for non-hospitalized patients were signed by the patient. He agreed not for further supportive transfusion, which also facilitate home care. The patient succumbed on the next day. In summary, this is a case of HIV advanced Kaposi sarcoma with systemic involvement failed chemotherapy and radiotherapy, in which patient finally opt for symptomatic care. The key challenges identified in this case will be how to facilitate advanced care planning in a critically ill young patient, and how to facilitate the transition from active disease treatment to palliative care. Thank you.
Thank you very much, Chris, for presenting this very tragic story of this patient. First of all, are there any questions from the audience regarding this patient that you would like Chris to further clarify or provide more details? PLHIV?
Hi, Chris. Thanks for presenting that. Could you kind of elaborate a little bit more in terms of what kind of conversations were had with the mother and whether the mother knew about him having HIV?
Yes, thank you for the question. I think indeed the patient did not meet his mother frequently before the diagnosis of HIV and also the Kaposi sarcoma. The patient actually went for what we call working holiday and defaulted follow-up for more than 1 year. But unfortunately, the patient come back, present with the gum swelling. Then that brings to the attention of the mother, who then finally come to visit with the patient to our clinic. Actually, we did explain in details the diagnosis, the management, what our collaboration with the oncology team for the care of the patient. During this moment, actually, the mother of the patient really felt a little bit, guilty, because the patient mother did not know much about the disease. And of course, mother will worry about his son getting of such an illness. After explaining the medical condition, we do have our clinical psychologists try to help us to explain and try to relieve the stress of the mother. And we do hold some meeting with both the patient and also mother to update frequently on the treatment response, the prognosis of his disease, and hoping they will know more about their condition in step by step.
Thank you.
And Sister Hong?
Thank you, Chris, for the presentation. Actually, this question is not related to ACP. But I just want to ask the expert here that do you see heterosexual male with Kaposi sarcoma often?
I think we do not see quite such a severe case of Kaposi sarcoma. Usually they will succumb with, but usually they will the condition will improve with antiretroviral therapy. But to these kind of systemic involvement, needing course of first line, second line of chemotherapy, radiotherapy, which is fortunately not that common.
Yeah, I also look after a patient who has a visceral Kaposi sarcoma with very extensive involvement also. And the patient went through a very stormy stay in hospital, have to admit to intensive care unit for treatment multiple times, and also went through multiple lines of chemotherapy. But fortunately, the patient, probably the patient is quite young also, so the patient was able to recover. Yeah, thanks for the sharing.
Kejal?
Grace, thank you very much for such an interesting but really sad case. I'm just curious, I'm sure the oncologist could have had already prognosticate how the patient is going to do given the aggressiveness of the tumor, and he eventually did get TPN. I'm just curious on how did that conversation go, because I'm coming from a geriatric point of view. So TPN means putting in a PICC, completely not being able to, swallow anything. I knew he had obstructive symptoms, but I wonder whether if what mattered most to him is I want to still drink, even though I know that I might choke or I might aspirate, rather than having a triple lumen here or a PICC. So I'm just wondering if that conversation was done and how did that conversation go?
Oh, yes. I think at the first time, the patient actually still want to have, even we put in a rice tube, he still want to drink. He still want to have his own nutrition, choosing his own favorite food. But till the very severe obstruction of the upper digestive tract, the patient actually complained he can never drink or eat. He will involuntarily vomit after eating. So because at that stage we still want to fight for the patient. We as the nutrition is an important component for in this case taking care of the on call for the tumor. So we choose the TPN, but hopefully at that time we hope for the best for the tumor to try to shrink a bit and then can tolerate oral diet. But unfortunately, the patient cannot.
A follow-up question. At the very late stage of the illness, the patient chose to be discharged from hospital and going home. So, how long actually had he been staying at home before he finally succumbed? And also, while at home, so how was the feeding arranged during that period?
Yes, actually, the patient can only go home for a few hours. And at night, we need to sort of clinically admit the patient. back to the hospital, because in Hong Kong, it's still not a very common practice for even a cancer patient to die at home. They will usually call the ambulance, but for this case, we choose to because to respect the patient's final wish to go home with the family, and anything we can help is if they feel unwell, we try to clinically admit, but not through the A&E, to our center for further care. Actually, the patient come back in the night of the same day that he went home.
Okay. You just now you mentioned that the clinical psychologists had been providing great help to the family and the patient in the process. So I see that Barry is here. So hi Barry. So I'm not sure if you are the clinical psychologist who have provided help, or you have any uh, comments for this patient. I think one of the issues that Chris has raised at the end of his presentation is for these very young patients with terminal illness, sometimes it's very difficult for the patient and also for the parents or family to accept palliative care, end-of-life discussion. So you have any advice or comments for us?
Yes, he was actually one of my patients as well. So back at the time, we provide psychological support for him and as well as his mother. And we also opened discussion for him to talk about his feelings around impending death and also any unfinished business. And I think the journey was not just at the point. I mean, the point of intervention was not just right before he was about dying, but it was. I think our support started at the beginning when he was diagnosed with Kaposi sarcoma, and then we went through the journey with him. That when the first line chemotherapy doesn't work, and then the second line doesn't work as well. So and on the journey there was a lot of signs that would inform him that his prognosis is actually not very optimistic. So there would be also a chance for us to discuss with him about his feelings towards the decline of his condition and also possibility of dying. So that's like an ongoing process of managing his dying process. And also, I think around the time we also have discussion with his mother, sometimes like private discussion with his mother around how his mother feels about possibility of losing her son. And we also offer, I mean, in hospital authority setting, so in HA setting, we can offer a family member one more session after the patient died. So we arranged another session with the mother 2 months after the patient died. So the funeral was done, and then the mother was more able to process her feelings, so that she was invited to be back in the. Because remember, the patient was died around early November, and then the mother came back a couple of days after Christmas. So we had a discussion about her feelings and also how her family is coping with this.
Yeah, thank you. Chris also mentioned about the feeling of guilt. I couldn't hear very clearly whether that's from the mother or the patient, but from my practice, it's actually quite common that the feelings of guilt was triggered when the person or close family is actually encountering impending death. So for these very young patients, so how could this issue be dealt with at this time?
I think it's important for the mother to make sense about what happened, and also I think there is usually like a meaning behind the feeling, so that it would be usually linking to a thought or an image in her mind, so that we need to dig it out, and then so that we will be able to discuss it. And also for managing grief processes, it would be important for us to think about like some of the recollection of memory would be very difficult for her, and then we can have a chance to talk about it. And then these all sort of like memories or thoughts that would trigger her guilt or other difficult feelings could make sense in the picture, and then we can have a better formulation around why she would feel so.
Thank you. Pui, you have a question or comment?
I guess it's a comment and a question. I think it's really commendable that he had access to a psychologist so early already in his diagnosis. I think oftentimes it's something that we as physicians often forget to refer to a psychologist, or when it's referred, sometimes patients find it too early to be able to open up and speak to a psychologist. So I just think that is really interesting and great that he was actually engaged with a psychologist so early on. My question is actually, was there any kind of feedback between, the psychologist and the physician? Because obviously a lot was unpacked in those counseling sessions, and also, I presume in those sessions you were able to ascertain what was important to him in that journey, and what his priorities were, after the first cycle of chemo, second cycle of chemo, and so forth. So just interested to know if there was, any communication between the psychologists and the physicians in how they planned the treatment. Thanks.
Yes, I think usually we'll communicate with our clinical psychologist in our HIV meeting. Yeah, we should have every week. And when the clinical psychologist come to visit the patient, we'll usually we come and meet, and then we talk about the patient, the case first, the prognosis first, the treatment first, any progress of the patient, and then try to let everyone knows about the case and how we deal with the case, and any progress of the case. Then I think our clinical psychologists can really help us to try to convey the message. Sometimes our physician, as a physician, we what we deliver at that moment actually cannot be received by the patient immediately. With time, with our explanation, and with the help of our clinical psychologists, they will know bit by bit, and actually they will know much better. They will actually sometimes their query will put them in try to emergency, but if they know more, they will feel better.
Right. Thank you so much. That's really great.
Any other questions or comments regarding this patient? So maybe we can open the discussion for any questions we have regarding advanced care planning. Sister Hong, you asked us initially the question on what's the barrier in discussing ACP. So I guess most of our audience are coming from the Asian background, and one of the options that you've raised was the cultural belief or taboo in discussing death. I think for me, I think that's yes or no. It's sometimes hard for both clinicians or for patients to raise the issue of death, and that's maybe just out of fears, out of some anxiety, but more. I think it's really we don't know how to address, how to voice out our concerns or questions about this issue. And I think actually more and more people are being more open in or even want to have an open or active discussion or preactive discussion on ACP. So from your experience, do you think in an Asian community this is really a barrier, or we are just perceiving this as a barrier in preventing us to raise this discussion with our patients?
Okay. Thank you for the question. I definitely agree with you. It is a yes and no to the question. And we may feel that a lot of our older generation people are very fearful of talking about death, especially when they are getting older and older. But actually, sometimes it's not true. They may be quite willing and open to discuss about and plan about how they want to be cared for when they reach that stage. Actually, it's those younger people who choose not to think about it. They will say, I will just live one day at a time. I have not think about that. Even that when they already have significant multimorbidities, like suffer from multiple strokes, having heart attack, leaving them with a EF of 20%, and they still it's still hard to bring them to talk about this because they feel talking about advanced care planning may hasten that deterioration. So for this, I feel it is about rapport building and also having some guided question. We do not straightaway ask about what do you think about if you were to collapse, then what do you want us to do? So the question will be framed as in how do you want to be cared for when something happens? For example, if someone having a heart attack, what do you think will be the best for this person, in your opinion? So hopefully that discussion is more palatable. And we should always have a size out the patient when we start to have the conversation. That's why knowing about the understanding about ACP is important. If you feel they already feel very hostile about this whole session, they feel like it's the wasting of time talking about care planning, they just don't have any insights about such discussion, then I think we should not force them. We would rather focus on some goal, for their goal of care, how they want to improve, what we can do to help them improve. For example, functional status, for example, like symptom control. So there's always something that we could do, right? And we hopefully the subsequent session that we can slowly broach the topic. Yeah.
Thank you. And another follow-up question regarding who is providing this discussion on ACP. So you've mentioned about those three types of ACP, and one of those are the disease specific or triggered by having a more serious illness. So for patients with cancer or terminal malignancy, sometimes it's there's a rather clear point where we know that chemotherapy or oncological treatment would fail or there's not much choice. But we are now actually seeing more patients with organ failure, so like heart failure, renal failure. And sometimes it's not very clear at the point where we might expect more rapid deterioration or when to initiate this discussion of ACP. So the timing is my first question. And the second question is, again, who should actually be initiating this discussion? The reason I'm asking is that for many of our patients with HIV, very often the healthcare provider for the HIV care is their primary healthcare provider. However, when we are discussing issues like heart failure, renal failure, very often we might not be the best person in terms of discussing the medical care or the prognosis. So from your experience, how would you do that in Singapore? Would you involve like the multidisciplinary team, or will it be the HIV care provider doing this, or how you would actually do that?
Okay, thank you, Dr. Grace. So in Singapore, I think we are probably running on a similar model whereby HIV physician is the primary care provider, right? And we have much more encounter with the patients and a longer term of relationship with the patient. So usually we will also be the one who initiates the discussion. So I want to share my thoughts because I feel ACP discussion is not a goal. It's not that we must achieve the discussion, we must finish the discussion and have this form signed. The beauty about ACP is about starting the planning, starting the discussion, so that the patient can start think about it. A lot of time they do not think about it because one is because they may not know their health condition will evolve. They may not know, like exactly like us, how much time is there. When is a good time to start? So it is always earlier, the better, right? And yes, we are not trained in nephrology, cardiology, right? So we may not be offered some very specific information for the patient to make decision, but we can always offer a general knowledge so that sometimes it may be good enough for the patient because what we actually really want is to understand the patient's preference, how they want to live well, right? What is important? What does suffer constitute of? If they say, if I were to go to a center that they may volunteer, if I were to go to a dialysis center 3 times a day, sit there for 4 hours, 6 hours to do this, like hook on the machine, I feel that life is meaningless. That gives us some hint, right? So from there, we can bring the discussion further. And if need be, we can discuss with their like nephrologists, cardiologists. So I would say that it is not about arrive at a decision. And a lot of time our patient's decision change. So I will give an example. For example, this patient with end-stage renal failure. And all of a sudden, the daughter become pregnant, right? And this person from a very passive and negative kind of persona suddenly change to someone who really motivated, wants to control the fluid intake, taking the medication actively. So there will be some life events that happen along the way that change the patient's decision. And sometimes it can be the other way around. So it could be their loved ones, right? So for example, they'll be the main caregiver for their mother. That's what keep them going. And then suddenly the mother not with them already. And then suddenly they say, okay, I think that's it. My duty, I have fulfilled my duty and I'm done with it. So all these are patient's choice, right? And the timing is really, really difficult to say. So that's why we have to go with the patient. Yeah. Sorry for the long answer for the question.
No, yeah, well, I think your sharing of your experience was very valuable to us. Okay, so are there any other questions or comments for our speakers? If not, then I'll pass to PLHIV to close the session. Thank you, PLHIV.
Thanks, Grace. Thanks, Cheng Hong, and thanks, Chris, for a great session. It's a little bit solemn, but at the same time, I think it was an important topic that needed to be covered in this series of talking about HIV and aging. So I think just before we wrap up the session, I'm just going to share some slides just to kind of end us off after our 12-month journey. So hopefully you can all see my slides. So our journey really started in September of last year, and today is our last session. So we've done 12 months of sessions. And let me just go next. So I just wanted to say a thank you to all our hub members. Some of them are here, some of them are not. I just wanted to say thank you for your support and for sharing your knowledge so readily as well as your time. as well as to all our didactic leads, so all our subject matter experts that have given their time in the last 12 months to kind of talk to all of us and share their knowledge with us. I just wanted to share this slide to say thank you to all of you that have been coming regularly for our sessions or even come for one session. It means a lot for us to know that there are all of you who are interested in HIV and aging, and hopefully these 12 sessions have been able to kind of move the needle more internationally, to get more interested and more focused on HIV and aging and providing better care. So thank you to all of the participants from all over the world who have tuned in for this training. Majority of our participants are doctors, but also nurses, administrators, social workers, pharmacists, counselors, and research personnel. So for us, it's very heartening to see interest across the board from a multidisciplinary team of people, which is so important in the care of aging. And so I'd just like to remind all of you that all of these sessions are recorded. So if you missed any that you're interested in, you can scan the QR code or go to this link to access all of the videos of our previous sessions. And really, that's it to wrap things up. So a great big thank you to everyone. And that will draw us to a close for our echo session. Thank you very much, everyone.
Thanks very much.
Thank you.
Just a question for the iEcho platform. After finishing this last session, will it be still open to all participants to extract the resources that we will need in the future?
Yeah, as far as I know, I don't think it closes down. So the iEcho, all the resources would still very much be there. Yeah.
Okay.
And we'll be sending out an email to everyone with the YouTube link, as well as end of entire echo feedback form, just to get your feedback to see what we can do next. So thank you everyone for your support.
Thank you.
Bye.
Bye-bye.
See you.